Today I have the privilege to introduce Dr. Eugene An. Dr. An is a radiation oncologist at the Coastal Radiation Oncology Group. He's a graduate of the University of Washington, attended medical school at New York University School of Medicine, and completed his training at UCLA School of Medicine. He's board certified in therapeutic radiation oncology and has expertise in some of the most innovative aspects of radiation therapy, including stereotactic radiosurgery for precise treatment of tumors. Additionally, Dr. An has significant experience in brachytherapy. So welcome.
Yep, thanks. Thanks for having me. Yeah.
So to start with today, I thought we would talk about maybe the latest developments in some of the local regional control of breast cancer. For many years, the death rate for breast cancer has remained pretty much level and stagnant, and it really wasn't until 1990 when we actually began seeing a steady decline in the death rate. While screening mammograms programs in the early 1980s certainly played a role, the death rate continues to drop, and despite the accepted recognition of role of mammograms. So therefore stands the reason that other factors in improvements of breast cancer rates have got to be involved. But what are some of the local therapy options for breast cancer that's kind of led up to these improvements?
Yeah, so there are a lot of good options in terms of local treatments for breast cancer. It started with mastectomy, which has been around for a long time, and that was maybe the original therapy. And as we've moved along, all of these different local treatments have improved. Mastectomy's improved. You've had lumpectomy with radiation therapy, and now you even have modifications of these treatments, right? With maybe what we call neoadjuvant chemotherapy to improve outcomes and changes in the way mastectomy's done, which you know better than me, right? But yeah, that's there are a lot of options, and I think the key now is trying to personalize the treatment because the outcomes are quite good across the board, especially for early stage breast cancer. So it's really just a matter of trying to tailor the treatment.
So when you talk about having the evolution of mastectomy down to lumpectomy with radiation, I mean, what is the role of radiation after lumpectomy, and why if you just take the tumor, do you even need to have radiation involved at that point?
Right. Yeah. So that's a very common question. I hear that all the time, and then you hear the comment, well, if it's already out, why do you need additional therapy? And I think the answer is very simple, because there's a risk that the cancer will come back after lumpectomy, and the radiation serves as a very good cleanup.
So why can't you just irradiate the tumor? Why do you even need to take it out if the radiation is going to kill the cancer?
Yeah, so the radiation doesn't work that well, so we still need surgery to remove it. There may be situations where you could use just the radiation by itself, but overall it's better to have the bulk of the tumor removed, and then you use the radiation for what we would call microscopic disease. Yeah.
I mean, so you have the mastectomy, and then not compared to lumpectomy now with radiation. What about radiation after mastectomy? I mean, do all women need radiation? Why is it some women after mastectomy need radiation and some women after mastectomy and they don't need radiation?
Right, absolutely. So, most of the time mastectomy is enough, but there are situations where if you're dealing with a very large cancer, or if you're dealing with a cancer that's spread to multiple lymph nodes, then we would advise radiation, and that's, again, the same concept, which is there may be microscopic disease that even a mastectomy may not be able to remove. And studies, data has been pretty clear that in these situations you do that, you decrease the chance of the cancer coming back, and ultimately you're talking about a survival benefit, which it has been shown to occur.
So the radiation after mastectomy is basically selective and for individualized based upon the patient then?
Right, absolutely. So it's not something we recommend across the board. And if you look at the numbers, again, most mastectomy patients do not have to have radiation, but in certain situations, if the cancer is large enough or if there's significant spread, then we recommend it. And of course, there's occasionally a situation where there's something called a positive margin, where the cancer is just, not being cleared. So then you've got to do radiation then.
Right. So was it the tumor is right up against the chest wall or against the skin, where the surgeon is unable to take any more tissue? Then that's where we rely upon radiation, for example. Is that what you're saying?
Yeah, absolutely. I mean, so the role of radiation is to help the surgery, right, and help the surgeon, right, to clear any microscopic disease. It does a very good job in the microscopic situation. Recurrence rates are low, whether you're talking about lumpectomy with radiation, even in the more advanced setting. Radiation can definitely lower the recurrence rates.
So you said indications for radiation after mastectomy, for example, is like large tumor sizes, positive margins, but you also touched on lymph nodes being involved. So can you discuss the idea behind the sentinel lymph node biopsy as opposed to the old days where we would do an axial lymph node dissection, and how does that impact radiation and how you are going to treat these patients based upon the sentinel lymph node information?
Yeah, good question. So, which you know the answer to, but I'll
well, I mean, for everybody else's interested.
I'll answer. Yeah. So again, as you said, the standard was to do a complete axillary node dissection. And the problem is removing a lot of lymph nodes could leave some side effects, that especially lymphedema. And so the data came out, I wouldn't say recently, it's been known for a while that if you just remove a few nodes, especially nodes that are the sentinel nodes, then that'll give you all the information that you need. And so you can reduce the number of lymph nodes that have to be removed, which again reduces side effects, but you don't reduce the effectiveness of treatment. And that's because you can just take 1 or 2 lymph nodes out, and if needed, the radiation can cover the axilla and reduce recurrences, and so you don't have to add a full axillary node dissection.
What about, so how does that play into doing radiation as far as planning for you, whether you do a lumpectomy or whether you do a mastectomy? Does the involvement of lymph nodes alter how you're going to take care of this for the patient?
Yeah. Again, it's personalized medicine, so we have more and more data guiding us in terms of how to treat patients. So in a lumpectomy situation, in certain cases, you may not be all that concerned about the lymph nodes. And in situations of a post-mastectomy where several lymph nodes are positive, then obviously that's a concern. So then we treat an even larger area, right? We don't just treat the axillary nodes, we treat higher, all the way up.
What do you mean by higher?
Right, that's right, higher meaning nodes that are not just under the arm, but maybe a little bit deeper, and higher meaning kind of coming up into the clavicle area.
The collarbone area. And
the supraclavicular nodes. And so coverage of those nodes makes sense because if the cancer is spread to the lymph nodes, then you want to make sure you stop the spread of those of the cancer in those lymph nodes.
Yeah. Would you consider the sentinel lymph node biopsy nowadays to pretty much have replaced the axial lymph node dissection for most patients?
Yeah, absolutely. Especially in a lumpectomy, if you do a sentinel node and it's negative, right, we're done. And so that's always nice to limit the number of lymph nodes.
What if it's positive? Do they need the axial lymph node dissection?
Yeah, for most cases, you don't need to. I would, of course, discuss that with you, right? So that's a surgical call. But if we can, I think the data is clear that there's one node and you're going to do the radiation, that can help.
I think one of the strengths of, at least at Los Robles Hospital, is we have a multidisciplinary tumor board. And I think because of the multidisciplinary tumor board, it will work as a team. And I think a lot of the decision making that gets done is in the old days, a lot of it was the decision making was driven by the surgeon. But wouldn't you agree that nowadays we all kind of work together and come up with a kind of a collaborative plan?
Yeah, absolutely. I mean, that's one of the strengths of our program at Los Robles. It's truly a team effort, but it's, again, still personalized. So when we encounter a patient where maybe there's a question mark about, do we do chemotherapy up front, or we're going to do a mastectomy, or we're going to try to do lumpectomy, then we can bring that patient to be discussed, and you get a group of physicians to talk about, a real live patient's individual case. And then we can tell the patient, this is what the group decided, and there are multiple physicians involved, and you get better communication, and you probably get better care.
So the whole idea about the individualized care and personalized medicine, I think a lot of it is trying to meet the needs and the goals for the individual patients, what they're expecting out of this. And I think that what we focus on nowadays is trying to maximize effectiveness while reducing a lot of the side effects.
Right.
And that happens not just in surgery, but I think in radiation oncology too, right? I mean,
yeah.
So like, for example, as you were mentioning, in surgery, we've gone from the axial lymphodissection to the sentinel lymph biopsy, which is maximizing the effectiveness and, again, reducing side effects. How would you say in radiation oncology that has translated in your field as far as maximizing effectiveness and reducing side effects?
Right. So again, you're trying to tailor the treatment to the appropriate risk. So one clear example is maybe there's even a subset of patients where you don't even need the radiation, right? And maybe you could just do a lumpectomy alone. Mm-hmm. And if you choose the correct patient with truly low risk, and they're willing to be monitored with mammograms, they're willing to take the medication, you can even omit the radiation. And again, that's just trying to tailor the treatment to the patient or the appropriate risk.
So you touched on a topic which I find interesting, is actually for years and years we've always kind of driven home the importance of radiation therapy after a lumpectomy. But you'd mentioned that there are some cases of after lumpectomy you may not even need radiation. So it's kind of going another direction. How do you decide an individual coming in? You said low risk, but I mean, are there other things that help you make that decision?
Yeah, I mean, I think eventually some biological testing or genetic testing, like Oncotype, that'll really help us. But that data, especially in the radiation setting, is not out. But I think we still have good information guiding us. And specifically, if you have a patient that's a little older, a little more frail, and transportation's an issue, but the risk is low, meaning the tumor is small, they're estrogen positive, a low-grade tumor. These are good patients that you could talk to. And if they're willing to get mammograms. Technically, you're supposed to take medication, but a lot of these patients may not want to continue medication for a long time either. So again, it's a balanced discussion. I'm not saying that you can omit radiation for all patients, but it's an option.
How about this whole concept of hypofractionation, where they shorten the course? What is that all about?
Yeah, hypofractionation. So that hypo means bigger doses, and it also means that you're shortening the treatment from the standard of 5 to 6 weeks down to about 3 to 3.5. And I think the shortened course is more the standard now. Unless you're talking about, again, as we discussed, more extensive disease with lymph node positive, it's hard to go fast in those kind of situations. Mm-hmm. But after a lumpectomy, with early risk disease, you can go fast, and I think that's the standard now. So,
I mean, conventionally, what was the length? How many weeks would in the old days would radiation therapy take, and how short are you getting it down to nowadays?
Yeah. So, the old days, but I'm old enough to recall those old days, right, with you. But that was 5 to even as long as 7 weeks, 6.5 weeks. And we, just like with the Sentinel node and figuring out that you don't need to do a full axillary node dissection, we also found that when you compare patients who underwent 3 to 3.5 weeks versus 6 to 7 weeks, we found no difference. So if there's no difference, well, let's just choose the shorter, easier course.
The tissue around the operative bed is considered to be the highest risk for recurrence, right?
Right.
And then,
Right.
But when you do the whole breast radiation, you're radiating the entire breast.
Right.
So why do you have to radiate the entire breast if the only area that you're mostly interested in is around the area of the surgical,
Right.
what
Right.
the surgery was?
So you bring up a very good point, which is for most patients, when we talk about operative bed or brachytherapy, that's based on the assumption that most of the risk is around the operative bed, which is true for most patients. And so you can still do brachytherapy or operative bed treatments. It's just when you shorten radiation treatments to 3 weeks, once a day, sometimes that's just as easy as coming in twice a day for a week, and then you get the potential added benefit of covering the whole breast, which improves control rate slightly, not a lot. So then it's a balanced discussion with the patient in terms of what you want to achieve.
Because when patients get whole breast radiation, the things like lymph nodes and other parts of the breast are included in the field. But when you doing brachytherapy, for example, where you just radiate the surgical bed, or intraoperative radiation therapy, that part of the radiation field does not get included. Is that correct?
That's right. That's right. So it's again all trying to tailor the therapy to a particular patient and the risk. And so when you're talking about patients with multiple lymph nodes, then you have to do the whole breast and you have to do a lot of the lymph nodes. So then I wouldn't be giving good treatment if I just did the operative bed in a situation like that.
Right.
But then you could take the other end of the spectrum where you have a very small tumor, no evidence of spread to the lymph nodes, and then that it makes sense that maybe you could get by with just more limited coverage. And again, there's data to say that you could do more limited radiation fields. Again, it has to be tailored, because when you take large numbers of patients, there's always a few where maybe, even though you really thought it was low risk, maybe there is some tumor a little further away. So again, you're just trying to tailor the treatment to the patient, and as long as they're aware of the pros and cons, you have a multitude of choices.
It just amazes me the amount of advances we've seen in breast cancer over the past 5 to 10 years, and I just, not just from the surgical standpoint or the medical oncologist standpoint, but even from the radiation standpoint. And for as great as the advances we've seen over the years, I mean, I'm even more excited about the future. And I think it's because of people like Dr. Ahn and Dr. Eisenbud and other members of the oncology team. I think our patients will only continue to improve. I'd really like to thank you for the opportunity to do this for us this year. Again, for the Los Robles Hospital Breast Cancer Symposium. I think that we're very pleased and grateful for your input.
Right. Thanks for having me.
Yeah.
Hope